Welcome to the Radiology Economics and Policy Learning Electronic Toolkit, REPLETE. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this session is entitled Radiology Reporting, Medical Necessity Documentation. This module is targeted to Level 1 of the Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, such as interventional radiology or nuclear medicine, please reference the REPLETE resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are to describe documentation requirements necessary to obtain appropriate payment for common diagnostic radiology services, to identify opportunities to simultaneously improve care and enhance reimbursement in a systematic manner, to avoid common regulatory compliance mistakes, and to institute processes for team-based, continuous, improvement-oriented revenue management. Here are some additional resources listed alphabetically for those who would like to learn more about the topics in this module. What do your reports look like? Are they thoughtful and detailed? In a way that the typical consumers of our reports, our referring physicians, will consider them meaningful and actionable? Or do they look more like this? Ones that in an era of open patient portals may lead to unfavorable Yelp reviews. You see, there are many consumers of our reports. As we have talked about and will continue to talk about throughout REPLETE, our coders, and down the road, sometimes auditors, will often be reading those reports. And so our documentation needs to be done in a manner that they too can understand. Structured reporting can help a lot, as will systematic informatics and team-based approaches to capturing necessary information. It's what we need to do to get paid. It's all about the little boxes on the 1500 forms. Without codes, we can't submit claims. All of our reports need to include information about not only what service was performed, that is, information for CPT coding, but also why that service was performed, that is, information for ICD-10 coding. We're going to be focusing this module on the latter, medical necessity. As I've talked about before, and we will continue to talk about again in various nuanced modules down the road, medical necessity is really defined as the concordance between an ICD code and a CPT code. That is, the clinical information on your claim must support the need for the service provided. And the example I've used before, and will illustrate later, many along the way, is a CT scan of the pelvis, CPT code 72193. If you submit this with an ICD-10 code for appendicitis or anything related to that, you're probably going to get paid. If the only clinical history that goes to the insurer, though, is headache, you probably won't. In the REPLETE modules on documentation, we'll be taking a workflow approach, trying to help you understand holistically how we as radiologists get paid. We are all aware of our day-to-day work, interpreting examinations and generating reports. Those are both critically important for us in our roles, facilitating diagnoses and advancing patient care. And that documentation is duly important in our revenue chain. But there are a lot of things that happen before we provide those interpretations, and things that happened afterwards that are necessary for appropriate reimbursement. These are all opportunities to do better, and we'll be talking about those in modules, these and other ones down the road. My take-home message for today's module is whenever possible, obtain and document all pertinent clinical history. And there's two important words in there. Documenting the clinical history, that's your job as the radiologist when you're dictating those reports. But obtaining the clinical history, that needs to be a team-based approach where it's not just your job, but your entire team, both before and after you render your service. Optimal documentation is a team effort, and if you don't have medical necessity documentation in your claims to support payment, it's not just your fault. It's not just your technologist's fault. It's not just your business manager's fault. It's the result of many missed opportunities. Let me illustrate that with a few examples. Here's a patient who was referred from her primary care physician for a chest radiograph in your outpatient imaging center. She was sent over because of cough and fever. The ordering physician's request says, please do a chest x-ray. Clinical history, cough and fever. Your technologists perform a 2-view chest radiograph. You interpret that chest radiograph, and your impression is right lower lobe, lobar pneumonia. How are your coders going to code the diagnostic information? Well, they're going to follow the ICD-10 rules that we've talked about and will continue to talk about. They're going to code that to the highest level of diagnostic specificity that's available to them. Signs, symptoms, or specific diagnoses, in that order. So the order says cough and fever, signs and symptoms. Your impression provides a specific diagnosis, pneumonia. I'm not going to go into the details of what specific ICD-10 code we're going to apply there, but hopefully you get the point. There's diagnostic information there, and the coder will apply an ICD-10 code for the pneumonia that you describe. Let's go to variant 2 of that case. Same patient comes on in, referred for cough and fever, for a chest radiograph. You interpret the examination, perhaps good for the patient, normal chest, or negative examination. How is your coder going to code that? Well, the ICD-10 rules are the same. Signs, symptoms, or specific diagnoses. In this case, they're going to apply the ICD-10 codes for cough and fever, and by and large, this, like the latter examination, is going to get paid because these are going to meet medical necessity for a chest radiograph. How about the dreaded rule out? In our practice, probably like yours, we see this not infrequently. Rule out is a worthless order. Here's what Medicare says about it. In the Medicare Claims Processing Manual, if the results of a diagnostic test are normal or non-diagnostic, and the referring physician records a diagnosis preceded by the words that indicate uncertainty, and you can read the list there, but it includes rule out, then the interpreting physician, that's you and me, should not code the referring diagnosis. Rather, it's our job to report the signs or symptoms that prompted the study. That means we're going to have to figure out why it is that they want to rule out pneumonia. What does that mean in clinical practice? Well, let's go to variant 3 of this chest radiograph example. The patient comes on in to your office. Rule out pneumonia is all it says on the request. You interpret the examination, right lower lobe, dense consolidation, corresponding to pneumonia. Your coders are going to be able to code that out with that diagnostic information of pneumonia. Remember, the Medicare rules said that you can do that. But let's go to the 4th variant, and I think you can see where I'm going here, because that last study would have been paid. Pneumonia is going to be a payable diagnosis. Here, the order says it's the dreaded, rule out pneumonia. Your impression, normal examination. How are your coders with that information going to be able to apply an ICD-10 code? The bottom line is they can't. And you're not going to have adequate diagnostic information to be able to support the claim, and you're not going to have the complete information necessary to even submit that claim. So again, this is going to go back to this follow the money approach here. When all you have is rule out pneumonia or rule out anything as your history, you've missed many opportunities to capture medical necessity. Look at all those steps that happen before you interpret an examination and generate your report. The referring physician is going to be filling out an order form. This is an opportunity, if you're seeing that frequently from particular offices, to educate that office. How about working with the forms that they use, which may be part of your computerized physician order entry system, to be able to help them map their requests to the most common diagnoses, and of course give them an opportunity to fill in other. How about when that patient gets scheduled for the examination? Hi, I'm calling from Dr. Smith's office, and I'd like to schedule Mrs. Jones for a chest x-ray. Your technologist, your scheduler, whoever's taking that phone call should be responding. Why are we doing that? And if the answer is rule out pneumonia, then this is an opportunity to say, can you provide us some additional information? Or perhaps we can work with the nurse or the doctor to get that. How about when that patient shows up? Hi, I'm Mrs. Jones, and I'm here for my appointment. Oh, thank you, Mrs. Jones. Welcome to our practice. I see here on your request your doctor's writing rule out pneumonia. Can you tell me more about why you're here today? It's an opportunity to capture that information. And how about our technologists? Hi, Mrs. Jones. I'm Bob. I'm your radiologic technologist, and I'm going to be taking your x-ray. Dr. Smith indicated that she was worried about pneumonia. Can you tell me more about why you were here? This is an opportunity to capture information at each of those touch points with the patient. It's something that Dr. Matt Hawkins has written about in the AJR. What, when, where. Capture that information from your patients whenever you can, when the clinical history that's otherwise coming to you isn't inadequate. Legitimate history is legitimate history. Some folks will say, that's not my job as a radiologist to capture that information, or I'm not allowed to do that. Medicare says otherwise. In the claims processing manual, they particularly give us permission to do that. When the interpreting physician, that's you or me, does not have diagnostic information as to the reason for the test, it is appropriate to obtain the information directly from the patient or the patient's medical record if it is available. So use your team to be able to follow that information and those directions from Medicare. Your technologists are your friends. What, when, where? It's something that you can train your entire team to ask. The most common scenario in which we identified inadequate ordering clinical information from our referring physicians in our practice was a setting of lower extremity venous duplex examination. Rule out DVT was something we unfortunately saw pretty frequently. So my colleague, Dr. Courtney Moreno, took a team-based approach to this and led an effort to use our sonographers to capture that information. After all, they're in the room with patients talking with them while scanning them for quite a while. So we asked them to document the answers to a series of questions, largely related to what, when, and where. Afterwards, we used two different models, focusing on how different Medicare contractors covering those services. But we found that engaging our sonographers to capture that information so that we could record it as radiologists in our reports increased our chances of submitting clean claims, meaning better payment, by 20 to 30%. It's not hard. It just takes some work and a team-based approach. Importantly, never make up clinical history. Sometimes all you get is rule out. This is a real report that I dictated on a Saturday morning in my former private practice. It was an ER stack, and all I had was rule out fracture. I dictated in my report honestly and compliantly. I don't want to go to jail for this stuff. Rule out fracture is the only provided clinical history. But that information, that buzzword that I included in my report is critically important because that allowed us then through word search algorithms down the road to be able to identify a way of capturing better clinical history. When we saw that phrase, where is it coming from? Is it reports from our emergency department or outpatient imaging centers? Do we see it on weekdays or weekends, daytimes or nighttimes? Some hospitals in our health system or others. These are all opportunities for training your team to be able to do this better. The reality is, it is what it is, but never, ever make up clinical history. Some folks have talked about saying, rule out pneumonia. When I see that in my practice, I just change it to pneumonia. That's violating Medicare rules, and that will get you into a lot of trouble. And here's another real case of mine. Unhappy was all I had. I'm sorry, I dictated what it was. The patient had already gone by that time or was somewhere else in the system. And I used the opportunity through the word search algorithm system we set up to be able to help us improve our systems moving forward. Don't make up clinical history. Now, some physicians may say, this isn't my problem to do this stuff. I'm a doctor. That's my biller's problem. But if you're ultimately pocketing the money from Medicare, getting paid for your services, Medicare considers this your problem. Radiology, unfortunately, has been in the crosshairs with some pretty visible settlement agreements with the federal government. I've redacted the information from this public Department of Justice statement because there was no admission of guilt for this group, and for all I know, this could have all been related to honest mistakes or perhaps even malicious whistleblowers. But the point is, this radiology group wound up settling for some $2.5 million with the federal government because of allegations of improper billing. This is your problem if you don't do it well. Here's another radiologist. Again, no admission of guilt. He may have just been an honest guy caught in the crosshairs for a variety of different reasons, but he settled for $7 million with the government. The teaching point here with these cases is not who was involved or what the allegations were or whether they were even true or not. It's that we are all expected as radiologists, as physicians receiving money from the government to do this right. Future modules will focus on how you can set up systems in your practice to mitigate your compliance risk. Your coders are part of your team. They're your friends. And so when a coder calls you up and says, Dr. Duzak, there's a question I have about your report. You documented something, I don't quite understand it. Or better yet, they're coming back and saying, you say this way. Would you consider it saying this way if that's what you really mean? Because it'll be clearer to me. Don't hang up on them. Take those phone calls. Thank them for calling you. Because effectively what they're doing is they're handing you money by providing you that important advice. Simply responding back that, the documentation is already in the chart. Here's an old paper chart. Perhaps I'm showing my age here. We're all living in an era of electronic records right now, but they're sometimes equally unintelligible. In this situation, the hospitalist wrote for a consult for GI medicine for AP, which stood here for abdominal pain, but 2 lines later stands for abdomen and pelvis. The handwriting is barely legible, and even if it is legible, this is not available to your coders in their systems. And it's hard to dig up later from the chart if you're audited. So it's imperative to get the best information up front and document it contemporaneously in your report so that it is memorialized down the road. Don't just rely on hospital headers. They're frequently very inaccurate. Here's an example of a patient with an admission diagnosis of headache, and you see ordering diagnosis itch. Now, what did the referring physician really wrote in? ICH to stand for intracranial hemorrhage, but you can see how that could easily be mistranscribed into a diagnosis that may map to some dermatologic disorder. In this practice, which was really very thoughtful in this arrangement, they got their technologists to capture that what, when, and where, talk with the nurses when they're actually doing portable chest radiograph rounds, and capture this clinical information from the nurses at the time they're doing this, and make that information available for the radiologist to import into their clinical history. You can't trust hospital headers in a lot of settings. While our work focused on CPT coding, I think the same applies for diagnosis coding as well. Hospital headers are frequently inaccurate, and so relying upon that and them alone and not having the rest of your team involved in capturing correct information for you will lead to trouble, will leave you potentially with money left on the table. So in summary, Medicare and other insurers will only pay for services they deem to be medically necessary. In the payer world, that typically means that the ICD and CPT codes must match. Appropriate capture of information supporting medical necessity can influence both professional and technical revenue in a positive way. Team-based approaches to obtaining and documenting appropriate clinical history will improve both reimbursement and compliance. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Replete.